Hello, pharmacists and friends. Today is February 22nd, 2023, and welcome to the Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues. Listen to find out how pharmacists and pharmacy students like me can improve population health, health equity, and patient care through advocacy and education. My name is Jake Lawrence, and I'm in my sixth and final year of pharmacy school at the University of Rhode Island, working with the Rhode Island Department of Health alongside my professor, Dr. Bratberg.
And I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the College of Pharmacy and the academic collaborations officer at the Rhode Island Department of Health. What's going on, Jake?
Oh, episode 1. Excited to be here and jumping off season 6 with you. We got some good stuff coming up today. We've got a very special guest who was one of my previous API preceptors. So I'm excited to jump right in, get started, and see what we can talk about today.
Yeah, definitely going to have a lively discussion. Lots been in the news. This is a great topic suggested actually by your predecessors. So we're passing the buck maybe, but I think there's a lot to talk about here. Anti-obesity drugs. We pharmacists like to use acronyms like other professions. So GLP-1s or glucagon-like peptide receptor agonists. Let's just call them GLP-1s, but maybe you've heard of their brand names. No one sponsors this podcast yet. So semaglutide is the generic, also known as Ozempic or Wegovy. I'm probably not doing well with those names either. Tirzepatide or Mounjaro. And we're going to talk about the transformative role in diabetes and obesity management. We have an expert here.
Yeah, so important to know everything we're going to talk about today. Pretty much the data we have up until this point. This will be released a little bit after, so things might change after that. But today we have Dr. Lisa Cohen here with us, URI College of Pharmacy professor and a certified diabetes expert. As I said before, I spent 6 weeks working with Dr. Cohen on a prior API, working directly with community members. So I have firsthand experience of the impact and involvement of her expertise on the community in diabetes management. Most notably, I was delighted to be a part of her hard work in vaccinating the inmates in the prison system against COVID-19 and flu. So speaking for the prison system, stay tuned. We've got a podcast coming up next week, but let's focus on today. Dr. Cohen, please introduce yourself for our listeners.
Hi, thank you for having me here today. My name is Lisa Cohen. I'm professor of pharmacy at the University of Rhode Island. And I usually focus on things like diabetes, cardiovascular disease. So this is right up my alley. Thank you.
Awesome. We're glad to have you joining us. Since you're such an incredible educator to both our students and the community, let's jump right in and see what we can get going. So we introduced GLP-1s. We just start there and ask how these drugs work.
All right. So interestingly, years ago, back in like the 50s and 60s, they figured out that there was some other insulin that was being released from people eating. And so they did these studies and they saw that if people ate sugar versus getting sugar like through an IV, they responded even more with their insulin. And it took them until really the 1980s before some of these studies sort of were able to be released, but they still didn't know what exactly or be able to isolate particular chemical. And then they found it, and you may have heard of some people saying that GLP-1s from lizard spit. And they found out that the Gila monster, their saliva had the substance that would allow them not to eat very often. So anyways, we were able to isolate it. And then they started to create medications. And the GLP-1 agonists have been around. I forget the exact date, but exenatide was the first one to come out. And it was probably maybe 15, 20 years ago. It's been a while, but more recently, there's been a lot more attention to them for other reasons as well.
I have a fun fact. I did a lot of clinical trials. This shows up in all the work I've done, all the experimental drugs that I've done under study. And so when I was trying to pay for a trip to Europe to see my girlfriend at the time there, while I was in pharmacy school, they had this clinical trials unit at the hospital I was working at. And they're like, we're going to pay you money. And I'm like, well, you had me at that. And I was one of the first phase 1 recipients of a GLP-1. And it caused me to go into shock. And they were shocked to see me the next week when I came back to get the second treatment. So it was a very memorable experience. I think I was like a week away from graduating. I'm like, will I graduate? As I'm in Trendelenburg, my feet above my head. And then I came back the next week. I'm like, all right, let's do it. Checks waiting. Gotta pay for those plane tickets. So that's my GLP-1 story. But next question,
glad you're still here with us. All right, so we know a little bit about how they work. So what I'm hearing is that these drugs can help work for glucose management, help work for eating. They're not insulins. Can you speak a little bit on that?
Yes, what they're considered is they do not work and they're insulin dependent. And so what's happening is they don't work unless food is present in the gut. And then there's a substance in the gut called GLP-1 that gets released by the L cells in the small intestine. And that tells the pancreas, I see it, there's food here, go ahead and release more insulin. And so ultimately, it doesn't even wait for that sugar to hit the bloodstream. There's already some insulin being stimulated by the pancreas to be produced.
Nice. Okay. Yeah. So typically adolescent and adult patients who have diabetes or are likely to develop diabetes, current recommendations are weight loss, diet changes, and exercise. For those who need a little bit closer monitoring, you can do the finger pricks with the glucose monitoring, which can be time consuming and invasive on a patient's life. Or even needing the use of daily injectable insulins. So GLP-1s like Ozempic and Wegovy, which was approved a couple years later for the treatment of both diabetes and obesity respectively. These medications can kind of curb the need for all of this exclusive and repetitive monitoring day to day and still help monitor and reduce high blood sugar in these patients. So what is the current role in therapy and who do these medications apply for?
So they're meant for patients with type 2 diabetes. So those that are just from type 1, which is insulin dependent, early diagnosed, usually below the age of 30, it's not for them. This is for patients with type 2 diabetes. And it's approved for patients that are 18 and older, or all of them. Generally, their role in therapy it's interesting because it's changed just even in the last year. So I would say most diabetes people that work in that world kind of wait for those clinical practice guidelines that come out every year from the American Diabetes Association. And in there, they usually have a sort of a chart that tells you, where to prescribe. And this is the first year that metformin's not at the very top. It was very interesting. And we've been kind of waiting for it. We knew that we can tell by the data that's been coming out in some of the new studies. But there's some other reasons to use like the GLP-1 and some of the other agents that are on the market. Ultimately, this is kind of, I don't know if it's interesting or not, but all of the new medications that came out after in the 2000s, if they were for diabetes, they had to prove that they were beneficial for cardiovascular outcomes. So they could be released to market, but they weren't able to, the FDA would be considered to pull them if they didn't show at least cardiovascular neutrality or benefit if they could. And so just in the last, within the last decade, so many more of these studies have shown that the GLP-1 are not only good for diabetes and lowering sugars, but they're also good to help prevent cardiovascular disease and maybe even put them at lower risk for heart attack and stroke as well. So that's really why in the diabetes world, they've been pushed to the forefront and pushed ahead in the guidelines.
Have they been proven? So, I mean, this benefit on cardiovascular, I think we could have a whole podcast on the relationship between diabetes and cardiovascular health and why these are so intertwined. And a lot of the lifestyle modifications help both of those conditions. But do these have an effect on mortality? Because I always thought that metformin, that primary drug, had an influence on mortality, and then insulin, lots of old studies now that show benefits on mortality. Is that coming, or do we know that now? And maybe not even mortality, but like hospitalization. What are the effects on those outcomes?
So right now, the studies the outcomes that they're looking at have not been mortality, but they have been cardiovascular, so morbidity associated with it. So in that case, we know that like liraglutide, which is, the Victoza, and the Saxenda, which is for weight loss, semaglutide, which is the big hot one, which is Ozempic, and the Wegovy, and also dulaglutide, which is Trulicity. Those three drugs have been shown to reduce cardiovascular disease in patients with diabetes. So I think you're going to probably have at some point, so they'll extend those studies or do one of the follow-up studies and see if it did indeed reduce mortality too. But I would suspect probably, possibly, hopefully.
All right, so it's clear that these medications work and are fantastic for patients managing diabetes. What do you see the role being in patients with obesity?
Yes, so this is where obviously I think it's maybe TikTok set it off back in the fall. That's possibly what it was, or I think just the word of mouth that gets around. Certainly on a lot of the social media, we definitely have a big expansion of it. But the two drugs that got approved that were Saxenda, which is the liraglutide, and then Wegovy more recently. And when they came out, I think the outcomes and probably word of mouth from patients to see the benefit of crazy amounts of weight loss in some people. I'm a member on the Pharmacist Moms group, And it's interesting to see a lot of pharmacists have tried to take it or have started it. And definitely there's some side effects. And I know we'll be talking about that soon. But the weight loss, the people, their comments, even from healthcare professionals saying 20-pound weight loss. And some studies show, one of the studies shows like a 14.9% weight loss in obesity. That is huge. We know that even a small weight loss, 3 to 5% for hypertension is enough to lower blood pressure. Never mind, a huge weight loss like that.
Which I want to build on that because I believe it's Mounjaro that just came out that showed the highest weight loss in patients, somewhere near 20+%. So what is the greatest benefits of losing weight in both patients with obesity and those who have prediabetes or type 2 diabetes?
Yeah, so really, if you look at like what the FDA intended it to be, it would be for patients that have a BMI of 30 or higher, or 27 or higher for BMI. With
can you tell our listeners who may not know what's BMI?
BMI is the body mass index, and it's not the best way to evaluate obesity because Arnold Schwarzenegger would be like, his BMI would be way high. He has a lot of muscle.
I think The Rock's is like 35 or something.
Yeah. So it doesn't like tell you, if somebody has a lot of muscle mass or if they're, fit or something like that, and they just happen to have a higher BMI, but it's a measure of what we use in a lot of medical literature and things like that. And 25 or lower, well, not too low either. Between 18 and 25 is considered to be a healthy BMI for patients. And so if patients have 27 or higher with a risk factor or 30 or higher, then those medications have been super beneficial in helping them achieve their goals, ultimately, of getting BMI lower and hopefully reducing some of their other problems that they might have.
So what's hard here is that if a person is obese, it may cause higher rates or prevalence of cardiovascular disease. It puts them at risk of pre-diabetes and diabetes and risk of side effects when you have diabetes. So there's this like chicken and egg thing here where we know that, like you said, the lifestyle change, if you lose weight, you can sometimes take off high blood pressure medications, right? And I think even in diabetes, you can sometimes lower your doses or get off classes, right? If you just by losing weight. So now you have a drug that helps you lose weight, but also directly affects the pathophysiology, the pathogenesis of diabetes. So what's the effect? Like, what is this? That's why I asked about mortality. Like, is it, if you lose weight, do you have better mortality? I was always taught that you could be obese and exercise 200 minutes a week and you'll be cardiovascularly healthy, but have this higher BMI. And so it's really interesting to say like what, and again, I think we'd recommend everyone should be getting those recommended exercise and lifestyle, like all those things still exist. But man, if you lose 20 or 15% of your body weight, that's a cool thing, right?
Yeah. Well, I think
whether it stays off or not, we'll talk about that later. So like, what do you think is the benefit here? Because that goes into sort of the discussion about who gets these meds, who deserves these medications.
Yeah, I think certainly we have a problem with shortage as of right now, early 2023. And I think that that's going to impact, patients. And there's a lot of pharmacies that are waiting and only giving it to their patients with diabetes first, and then giving it to their patients for weight loss afterwards. But honestly, obesity is going to, in the next 5 to 10 years, be one of the bigger elements. We're going to really consider it to be not just oh, you're overweight, you need to go exercise more, but they're going to really place a lot more impact on that and how obesity affects so many different things. So I think, yes, I think it's really for everybody. Everybody should be, obesity should be considered almost equivalent to diabetes in some ways, because if they don't control it, they are going to have diabetes. And we know diabetes has all those complications associated with it, not just cardiovascular, but eyes and kidneys and neuropathies and all those other things that go with that.
And the American Academy of Pediatrics, I don't know if you treat pediatric patients, but I know that they just recommended, I think these drugs, even though you said they're only approved 18 and up, but I think AEP said 12 and up, if kids are obese because of these long-term side effects, to do active interventions. Do you know more about that?
I don't usually do much personally with the pediatric population, but I keep up with what's going on with them. So metformin was being given to kids before it was approved for that lower age. So this is, I think, a good step towards getting kids to be, more widespread use of it too.
Yeah, and I believe, I don't want to step out of term, I don't know if I remember it exactly, but I believe it was somewhere around like a BMI of 35 or 40 in those adolescent age who've like gone through a couple steps first, or like lifestyle management wasn't working for them. I think there are special circumstances where they are prescribing this for children under 18.
Insurance coverage is going to be the big thing here. This is
Yeah.
and I feel bad we're using these terms, but anyway, the idea that, what if your BMI is 34? Is your insurance going to cover it? So you're 15, your BMI is 34. Clearly, you'll probably benefit. There's data to support that. But if there's not an official approval, off-label use is going to have trouble with insurance coverage. And these are costly drugs. And we'll talk about that. So that's like a whole other segment here. But the costs are also in terms of these are not side effect free drugs, right? So it's great that you're losing weight, but at what cost? Can you tell us more about side effects that you alluded to earlier?
Yeah, sure. Just like anything, even vitamins can have an adverse effect. They do have a lot of side effects. And I think that's what held them back at first from being so, I guess, picked up by the general population, because I would warn patients, like nausea is going to happen like 20 to 40% of the time. You're not going to vomit that often, but it's pretty high. Like they say it's between 6 and 16% for actually vomiting. I think the numbers are lower now that it's been in use from patients that we speak to and from the amount of patients that are able to continue taking it. Those are some of the more common. And I think the other one that's kind of bothersome, and it varies from one GLP to another a little bit, but constipation, because one of the things that they also do is slow gastric motility. They slow down how the gut clears out your food and things. And because of that, constipation is an adverse effect. Feeling full, which some people don't like that feeling overfull, which is one of the benefits and why the satiety works so well. Hypoglycemia, low blood sugar, can happen if they're using it with insulin. And so they do recommend that if somebody, say, had type 2 diabetes and they're starting one of these, they should cut back a little bit on their insulin because they're going to expect their sugars to go down. By themselves, the GLP-1s generally do not cause any low blood sugar. And then the bigger, sort of more rare side effects, but the things that people worry about: pancreatitis, gallbladder problems, acute kidney injury. And then, of course, we do have the warning on that for a thyroid C-cell tumor. So patients that have that in their family, first degree relatives themselves, really shouldn't be taking this class of medications.
And that thyroid condition is actually exceptionally rare, which is why they detected it in the studies. But can you give more background to like how rare that is baseline and then in people using these medications?
Yes. I mean, I don't have the exact number of how many cases, but it's out of the thyroid cancer, which is not a common cancer anyway. It's very low. It's a very rare type of cancer that can develop. And it probably has something to do with the effectiveness of how we get insulin to work. There's some cancers that when you have certain pro-insulin effects, they can sort of exacerbate some cancer growth. And it happens with insulin itself too, people that take insulin. So it's just rare that it came up with that particular thyroid cancer.
All right, great. Well, I wanted to shift the discussion to the popularity that it's arose, and we've alluded to. So we've discussed how extra body weight and prediabetes and type 2 diabetes can contribute to lifelong complications, heart attack, stroke later in life, and how even obesity should soon be considered a chronic condition in itself. So it's not hard to think of these medications as potentially life-saving, especially for groups of people who typically face stigma for diabetes or prediabetes as diseases associated with sugar, food intake, and have a lot of stigma associated with them. But from a societal perspective, the dramatic weight loss effect observed with GLP-1s and these medications is what really caught the public's attention, not kind of their significant medical benefit. So I think that's something that we need to discuss. And do you think these medications will be lifelong for people who start on them? Or do you think this will just be a phase, take it to lose the weight? Or where do you see these down the line?
This is where I think social media it made it seem like you just start it, lose your weight, and then come off of it. But the real true recommendation is that once you start on these agents, then GLP-1s, these are lifelong. It would be, unfortunate if some patients were, this happens a lot, they start on it and then their insurance company changes coverage and they have to come off of it. But the studies have shown that there's been a couple of them. One of them was done last year in JAMA, actually 2 years ago, 2021, where they had medication. They actually started on semaglutide. They were on it for 20 weeks and then they stopped it. And then patients were split into two different groups. Half of them continued and the other half went on to placebo. And we saw that the patients that were in the placebo group, not only did they go back to baseline, but they ended up gaining a little bit more weight. Whereas the people ended up being 68 weeks, 48 weeks additional, just about another year, continued to have weight loss. Not continued, eventually they plateau a little bit, but the weight loss remained. And it's really probably due ultimately to the way it changes your satiety, that it hits your brain and the hypothalamus, and it tells it, you've had enough food. and people really do feel full. And when you take that drug away, after about a week or two, it goes back to, sort of regular, the way you were prior. Unless you could fix that chemical without it, you're probably going to be lifelong with these agents.
I actually did read that same article as well. It was surprising that when they switched back to the placebo, it wasn't just, a bit of a weight gain or gain back the same amount, but a significant amount of them gain back an excess amount of weight as well. And a couple of the articles we read in prepping for this, people who may have a history of eating disorders, binge eating, anything like that, once they stop these medications, that mental comfort eating or whatever the source of the binge eating or eating disorder might be, came back with full force, if not even worse. And again, these people were experiencing significant weight gain past what they had before they'd started these medications. So I guess where are you with the use case for these and how we're approaching the weight loss with it, if it's for some sort of eating disorder or what the source of maybe the obesity in a person may stem from?
I mean, it's interesting because it sort of brings to mind, the idea of, there's so many screening guidelines that primary care has to do. So it's like you say, we'll screen for substance use disorders and eating disorders and gambling, just like, it's just impossible to do in any kind of primary care clinician. But it's interesting is that I'm guessing there's data that people with eating disorders are seeking out and accessing these drugs, right? They're still prescription medications. And so that's a real, I would say that's a bigger concern than the side effect of the thyroid cancer, again, without family history to say. Because once you start, it sounds like what you're saying, Jake, and we probably need more research on this, that you end up worse if you come off of it, or you perceive you should come off of it, or as Lisa said, that if your insurance says, no, we're not going to cover this, which happened this fall, I believe there are insurers who are like, no, we're only going to cover, right? Which one was it? One of the manufacturers said, oh, we're having a supply problems. We're only going to cover it for diabetes. Did that happen?
Not that I know of that way, but I know
Okay.
like Mounjaro had coupons when it first came out. And so a lot of them at the pharmacy, they weren't going to be able to continue their Mounjaro without a diagnosis of diabetes. So people were sabotaging themselves and gaining weight and trying to cause diabetes so they could maintain on it, yes, to qualify for the drug.
Well, that's a good segue into Jake's excellent expose on social media and Ozempic's role here.
One more thing on the last topic before we move on, but it's one of those things too where it's like, we know the effects of this medication, it will work for most people. They will have significant weight loss. But again, if it's something like it stemming from an eating disorder, that's a mental health issue. Is this going to be the right treatment when maybe we should be tackling it from a different perspective first? Because again, then, once you go off of it. So what is the appropriate use case for these medications? We'll move on to my social media extravaganza here. So GLP-1s have recently become a cultural phenomenon, as we know. If you search Ozempic on TikTok, the world's fastest growing social media platform, there's tens of thousands, if not millions, of comments, videos linked to Ozempic, Wegovy, with people detailing their weight loss experience. The jury's still out, as we've discussed here today. There's a strong split between those who love the success they've found and how quickly they've shed the weight, but there is a strong support of people who report absolute misery using these medications, throwing up after meals, total loss of appetite, again, the frequent nausea and fatigue, brain fog, laziness. But despite these reports, there's still many people who kind of report these stories, but still take it anyway, because they value the weight loss more than suffering a lot of these unpleasant side effects that can accompany these medications. So kind of shocking to see the split, how people react in that, weight loss can really kind of be a big drive to still suffer through a lot of the things people experience when they take these medications for weight loss.
And to be clear, these are people who don't have diagnosed eating disorders. This is just
this is just general perspective, people reporting who have started these medications for the indication of weight loss.
And do you, Jake or Lisa, do you know anyone who, personally who's taking these medications and what their experience was?
Well, I'm sure you have some stories in practice, Dr. Cohen, so I'll be brief with mine. We're going to have on one of my personal friends who recently started Saxenda and discontinued because she just couldn't maintain taking it every day. She would have toast for breakfast and, just couldn't seem to manage making it through to the next meal or even suffering through the fatigue. And as a medical professional herself, she looked back and she's like, well, now I know there's a shortage going on. I had trouble getting this medication and I've got 3 pens in the fridge that are going to go to waste. Now, just a quick segue to additional special guest. We have one of my personal friends and colleagues, Angelina Aguiar, who's a registered nurse on. Angelina, could you introduce yourself for us, please?
Hi, my name's Angelina. I graduated from URI in December of 2021, and I've been working as a registered nurse since then. Last fall, I got referred to a weight management, weight loss specialist, virtual visit, never met really in person or anything like that. First visit, she started off and she was recommending bariatric surgery, like right off the bat. And I was like, ooh, that's kind of a lot. We maybe start with like a less invasive option or, some other things before. Because, I've had my weight up and down since I've hit puberty, done all the crash diets, the fad diet, but I've never tried any medications or anything. So she recommended Saxenda for me to start with. It was readily available at the time. And, based off my medical history and my eating habits and everything like that, she thought that it would work really well for me.
So she recommended Saxenda for you. What was the prescribing process and actually obtaining it like?
Before I had started taking the Saxenda, we talked about monitoring. She was a little bit unsure of whether the insurance would cover it or not. I'm not a pre-diabetic. I don't really, have any direct health problems related to my weight right now. So, not sure if they would cover it or not. And it's very expensive out of pocket. When she had put the referral in, call from my insurance saying that like it was covered and everything, I was really shocked. So for a 90-day supply, I was looking at $180 out of pocket, which, at first I was like, oh, that's a lot. But then I looked into the details and without coverage, it was $3,905. So I was like, all right, definitely, worth $180. Let's try it. So, for me, it was very straightforward and I'm very fortunate that my insurance was able to cover it right away.
We're seeing a lot of those insurance barriers where they don't want to cover it, or it can be super high cost out of pocket, or there's step therapy and other options need to be tried first. So it's really interesting that your insurance covered it so easily and quickly for you. So once you picked it up and started the medication, what was your experience like with it?
I've never had a prescription where I had to inject myself before, but it was very straightforward on using it. The first week, I was pretty fine. I mean, I started feeling small changes. Like when I was hungry, I would notice my stomach wouldn't growl. I would just kind of get like these like cramping sensations. I had a little bit of stomach discomfort. I wouldn't really call it nausea, but it was just, a little bit of discomfort, which I wasn't sure if that was normal or was it not normal. But after that first week, that's when I started getting like the heavy nausea. Started interfering with my day-to-day life, with work. I was super nauseous, just feeling like I was going to throw up all the time. And then by week 3, I was puking every day. I mean, like I had to call out of work because I was puking. I had to go home from work early. I would throw up in the car on my way home. I was losing weight at this point, but it's like because I wasn't able to hold down any food. It's not like I was like, there's no way this is healthy. I feel like I'm starving myself because I literally can't hold down any type of food. At that point, I just made the executive decision to stop. That was the end of the Saxenda for me. I can't give it to anyone else to use. I mean, I'm just gonna have to waste it. I don't really know. Literally sitting in my fridge and I have no clue what to do with it because like I can't share it with anyone. It's prescription. Like I can't sell it anywhere. I can't return it. So now I just have this massive supply.
Well, thank you so much for coming on to join us, Angelina. We really appreciate you coming on for the regimen for anti-obesity medications. Anything you have to say about GLPs and any advice for patients who are looking to take them in the future?
Yeah, I mean, if it sounds like it's right for you, if your insurance is going to cover it, if you've struggled with weight loss before and, haven't been able to really stick with results, I say try it. It's not for everyone for sure. Definitely wasn't for me, but there are people out there that it works for. So if you're in the position, spend a few $100 if your insurance will cover it. Try it. If not, there's other things out there.
Awesome. Thanks again for coming on.
Yeah, you're welcome. Glad I could be of help. See you soon.
That was Angelina Aguiar, registered nurse who took Saxenda. We're thankful she would come on and share her testimony with us. Now back to Dr. Cohen. Anything you'd like to share, Dr. Cohen?
Yeah, I mean, we definitely have lots of patients on it through the years that I've seen that some just cannot tolerate it and came back and said, don't ever give that to me again. And then other people said, oh my gosh, I used to fill my plate this big and now I still do that because my eyes tell me that's the right amount, but I can't even eat half of it, and that's for them, like, it's a miracle drug and all those kind of thing. Personally, my sister-in-law, who I'm guessing probably won't listen to this podcast, she doesn't do podcasts. Hopefully she started on it back, I think she said for my niece's wedding, which was in the fall. And she has lost about 25 pounds. She's intending on coming off of the medication. And I already have talked to her about it. And I said, probably not a great idea. You're probably going to have to be on it for forever if you want to, she's like, no, I think I've learned how to cut back. But she also noted as a side, she doesn't drink as much alcohol either with it. She just feels full.
Oh, that's interesting.
So that's like, it was a little interesting side note on these drugs too, which I found kind of, because people don't always tell you about their alcohol intake, but
Yeah, I'd be really intrigued to see data on that and see if other people report the same thing.
yeah.
That's cool.
Well, it's interesting because in the prep for this, which I never knew, when I worked in acute care settings, we'd have people post gastric bypass. It was a frequent surgery done at the hospital I worked at, and I worked on an ICU service and an infectious disease service, so we treat those things and those folks. And prepping for this, and in the lay media, or it would talk about how there were substance uses, particularly alcohol use disorders, would develop in people who had these surgeries, which are covered by insurance, also effective, but like a long recovery. Sometimes they fail. Very few people who qualify actually get the surgery, because it isn't social media like, hey, inject this and suffer through by vomiting every day. People are like, I'll do that, as opposed to a 2-month or 1 month, recovery from a gastric sleeve or these kinds of surgeries. So that's kind of interesting. So we don't have time to discuss all the ramifications of how society values people. Again, just being very clear, that's its own podcast. Where do these drugs fit? How do we value the size of people? And looking at other FDA approved obesity drugs, which all had basically marginal efficacy and actually probably more side effects, or equally number of side effects. Some were even withdrawn, and also resulted in rebound weight. So we have this experience of, Lisa said, is a predominant problem. We need effective drugs. We have effective drugs. We had ineffective drugs that people didn't take or had intolerable side effects. Now we have drugs that have somewhat tolerable side effects. You have to take them forever. We don't know. So access to these medications, like all medication access, hinges on safety and efficacy from clinical trials. But the other issue is finances. Jake, you want to talk about that?
Yeah, so I think it's important to address price differences between these medications and insurance coverage as well. Got a little blurb from the New York Times on one of the executives at Novo Nordisk, who manufactures Wegovy and Ozempic, two of the most popular ones, both used for different indications. Wegovy for weight loss, Ozempic for type 2 diabetes. And their claims are that these are separate categories and separate marketplaces to kind of explain big price difference between the two. I believe it's, $500 to $600 in difference for like the cash price of these drugs. And as Dr. Cohen, you mentioned earlier, people are trying to get up their blood sugars or find some way to qualify for these medications, especially during the shortages. We found some testimonies and articles of patients who would have been forced to pay thousands, $1,500 out of pocket for a drug that wouldn't be covered because, they didn't meet the indication of type 2 diabetes, when suddenly that their provider found, oh, well, you do have a high A1C or you do have high blood sugar. So luckily, we can say that you qualify. And suddenly the copays go down to $70, $50 a month for these drugs. Whereas last week when, they would have had to pay $1,500, that's quite a big chunk of money for a patient to be forking or trying to manage for their health conditions so that they can improve their long-term health. So give us your thoughts on the price difference and how you think these medications are covered, where there may be some discrepancies.
Yeah, it's probably one of the most disappointing parts, because they say that, if you have diabetes, it's going to probably be covered. I think the average copay, they say for diabetes coverage of the GLP-1s is around $40 for a month, which is still kind of high. For the most part, it's a tier 2 or 3 medication, even covered under diabetes. But then you add in the weight loss, and, Medicare does not really cover for weight loss yet, although some managed Medicare may do that. But then you're definitely patients that are not as wealthy. Patients that are wealthy are able to pay cash when they want it and get it for, as part of, instead of going to the gym payments, they're paying $1,500 a month for the medication, but they're okay with it. So it definitely precludes all the patients that are out there that have Medicaid, or, even their commercial coverage doesn't cover the medication. So I think eventually they'll probably drop in price if the guidelines kind of push it up. And the obesity, if you look right now, I looked yesterday, obesity meetings, that's going on. There is one every other week throughout the entire world. So there's really not, unlike diabetes, that has just a few organizations, the obesity hasn't really got together and created one solid saying, this is what we should do. And I think when that happens, that might help change policies and change how our third parties cover some of these medications, because they can't agree. They're like, no, we don't want this one, or that, that kind of thing. And they know that they should be used or could be used very effectively. But the cost right now is definitely for patients that have commercial coverage or beyond. I did just yesterday look up from my app about different states in our area, and also in some other areas too. And there are some Medicaid coverage of some medications. So you can see like Trulicity, for example, is one of the ones covered by Mass Health right now. Commercial varies. Like I was looking up one of the commercials in Massachusetts, like Staples, they prefer Saxenda and Wegovy to any of the others. So there may be deals because what Staples uses, I forget if it was Blue Cross Blue Shield or what, but others commercial for other employers were different. So it's not all hope is not lost. I think you're going to start to see some more coverage. The reason why they don't is because obesity is such a long-term thing. Why should United Healthcare cover your obesity drug now when you're not going to have them maybe in 5 years or 10 years when your employer changes? So that mindset needs to change somehow. We have to kind of all be in it or all agree to pay for it, I think, before it'll be more widespread, mainstream.
Well, there's certainly gaining prevalence now. So hopefully we can see these drugs, come up a little better on formularies, improve the cost to patients so that we can get these out there and improve population health. So what's the regimen for obesity medications?
I think these are there. I think for sure, right? These are have shown patients are happy generally with it. The patients that can tolerate it, love it, don't want to give it up. I think it's definitely in there. And I know, Jeff, you were talking about some of the things we've had in the past, like fenfluramine caused like valve problems. Like we've definitely had some burns with a lot of the older weight loss agents. And this one seems to be not only beneficial for the weight loss, but all of the other things that go with it, cardiovascular protection, diabetes, all of those things. So I think those are there. I think they should be.
Awesome. Yeah. So manufacturers, we need to see some changes to lower the cost for patients. The benefits are there. This serves a greater population of people than its original indications. And, hopefully we see progress in this area of medications for the future. I'd like to thank our future guest, Dr. Lisa Cohen, for being here today and providing amazing insight on GLP-1s and the rapidly expanding use and indication for these medications. Be sure to follow us at PharmDPubHealth on Twitter and Instagram. Subscribe, same username, at PharmDPubHealth on YouTube. And stay tuned for next week's episode on prison health with Dr. Justin Burke. Smash that subscribe button now, wherever you get your podcasts, Spotify, Apple Podcasts, Amazon Music, Google, and we'll catch you next time. Thanks for listening.
Right. Thanks.
Thank you.